The session today will be recorded. And again, we're brought to you by the Finger Lakes Geriatric Education Center and the Western New York Rural Area Health Education Center. Oh gosh, I don't know what that was, but all right, so the Finger Lakes Geriatric Education Center has been continuously funded by HRSA since 1999. We currently serve a 25-county area of the Finger Lakes region in upstate New York, but truly serve all of New York State through collaborations with many academic and community-based partners. Through educational initiatives targeting all healthcare providers and family caregivers, the goal of the Finger Lakes Geriatric Education Center is to transform clinical training environments by integrating geriatrics into primary care delivery systems, resulting in an age-friendly health system, as well as dementia-friendly communities. And the Western New York Rural Area Health Education Center is a nonprofit organization headquartered in Warsaw, New York, and the R-AHEC's mission is to improve health and healthcare through education. Counties in our catchment area include Allegheny, Cattaraugus, Chautauqua, Genesee, Livingston, Monroe, Ontario, Orleans, Steuben, Wayne, Wyoming, and Yates. The Rural Area Health Education Center addresses the health needs of its communities by focusing on health workforce development, preceptor development and student housing, pipeline programming, and rural healthcare technology infrastructure development. The reach and the mission of the R-AHEC made them a perfect partner to help us with this specific educational initiative. So we all know about the opioid crisis in this country, but to date there have been very few efforts to understand the impact and effects on older adults. Last month, the National Council on Aging published the results of a survey of over 200 community-based agencies in 40 states and Puerto Rico. The survey asked agencies to identify trends in the needs of the older adults they serve, as well as the agency's ability to meet those specific needs regarding opioids. And the results are not surprising. 70% of the agencies reported an increased effort spent addressing issues related to the opioid epidemic affecting their older adult clients or their caregivers compared to 2 years ago. And despite this increase, only 28% of the respondents said they routinely screen for substance misuse and abuse among the older adults they serve. 81% said older adults do not understand safe, effective, and affordable alternatives to reducing pain without prescription opioid medications. 80% reported that their older adults are facing challenges obtaining needed prescriptions or refills for opioid pain medication because of increased scrutiny and/or changing prescription patterns. And 80% said their older clients reported theft of pain medication by family members or others who use it for themselves to sell. So this survey is a great start to understanding some of the trends and challenges facing older adults and shows that we need more information, more dialogue, and more action to solve these issues, not only for the older adults, but for the caregivers, healthcare providers, and community service providers that support them. Thus, the Finger Lakes Geriatric Education Center and the Western New York Rural Area Health Education Center are pleased to bring you this webinar series featuring the most relevant information on the opioid crisis and how it affects older adults. Our featured speaker today is Dr. Gregory Collins. He is the Commissioner of Public Health for Wyoming County, New York. He received his Master's of Public Health degree from the University of Massachusetts, his medical degree from the Chicago College of Osteopathic Medicine, and completed his residency in family medicine here at the University of Rochester. He is also board certified in the subspecialty of addiction medicine. Dr. Collins' current areas of interest include implementation of medication-assisted addiction treatment in both rural emergency department and corrections settings. Dr. Collins maintains an active clinical practice, which includes medication-assisted addiction treatment, emergency medicine, geriatrics, occupational medicine, and correctional health services. I'm pleased to introduce you to Dr. Collins.
Thank you, Laura. I appreciate that. And good afternoon and good morning to all of you that have joined us. I appreciate the opportunity to participate in this series. I was looking through the different presenters and the upcoming presentations, and I'm looking forward to actually seeing many of them myself. From my perspective today, what I wanted to do was really present an overview of addiction and focus somewhat on the opioids, but just addiction in general. This is an overview for really all segments of the population, not specifically focused on older adults at this point, but just to kind of give a 30,000-foot view of addiction from many different perspectives. So there's several questions that have repeatedly come up as I've been working. One of them is, why do some people become addicted and while others do not? As a society, is our current approach to addiction working? And why is this particular epidemic, the current opioid epidemic that's been going on for the last 15 or 20 years, so explosive? Because it's certainly drawn a lot of attention to this particular issue. So I will attempt to answer some of those, probably not completely for all of them, but we'll do my best as we go through. I'm also going to look at addiction from two broader perspectives. One, the individual perspective, and the other more from a societal public health perspective as well. So the roadmap for the present starts in term definitions, because there's been some transition in the last several years of how we define things and what we're calling things. I wanted to go through a history of addiction and addiction treatment, primarily over the last 100 to 200 years, just to give us a frame of reference as to where we are right now. I'm going to touch on the neurobiology of addiction, which is basically the physiology of the brain and how addictive substances can impact that and do impact that. We're going to discuss the predisposing factors for addiction, and then get into some of the current treatment and intervention approaches. So terms and definitions. So the words dependence and abuse have been used for many, many years and are still used now, but have caused some confusion just because they are used in different ways, specifically mentioning substance abuse or substance dependence, which is kind of a broad term, psychological dependence, physical dependence, and then just the word abuse. So they've really redefined some of these terms and have started using a couple different general categories. One is what we call physiological dependence or physical dependence. That is an accepted term now, and I'll talk about that in a few moments. And then the other broader term is substance use disorder, and it's categorized into mild, moderate, and severe. And that's basically the addiction-specific terminology. So as far as physical or physiologic dependence, there's two components to that, withdrawal and tolerance. Withdrawal is where you actually have physical symptoms when you stop taking or decrease the amount of medication that you're taking. And these are based on changes that have occurred in the body because of the medication. Tolerance is basically where the body starts to develop a resistance, if you will, to whatever particular substance or medication you're taking, and you need higher and higher levels to achieve the same effect. Both of these are actually related to the physiologic adaptations of the body, doing what we would expect it to do when it's exposed to the substances or medications. And actually, both of these occur with substances that are both addictive and non-addictive. And we'll take a look at a couple of examples. So there's a class of medications called beta blockers, which a couple of names include metoprolol or atenolol, which are used for high blood pressure. There's the antidepressants, they're called the SSRIs, which include Zoloft and Paxil and many more. And then there's also opioids that fit into this group of actual prescribed medications. And just an example, taking the blood pressure medications, the body develops a physiologic adaptation to those. And if we stop them abruptly, you will typically see the opposite effects of the effect of the drug. In this case, blood pressure can increase, heart rate can increase, and that again is because of the body's adaptation to that. And basically, to avoid that, we taper the drugs off slowly or transition to one that's similar. It's no different with the opioids, which we're going to be talking about more specifically, where if you're on them for a certain amount of time, and that can depend on the individual and the dose and the amount, but if you stop them abruptly, you'll develop withdrawal symptoms that can include sweating, nausea, vomiting, chills, body aches, diarrhea, all some very uncomfortable symptoms. Uh, all of these medications too, as you take them, the body can develop a tolerance where you may need to increase doses over a period of time to achieve the same effect. But these are all physical changes and physiologic effects and don't really fall under the category of addiction or substance use disorder specifically, though they can be a component of it. The bottom line with this is that physiological dependence is not an addiction. So an example of this that we see fairly commonly, even in older adults, say somebody comes in for a hip fracture and is put on short-term opioids, which would be hydrocodone or oxycodone, and they end up taking them for 3 or 4 weeks until healing occurs and they're up moving around. They may well, when they stop those, develop some of the withdrawal symptoms, including some sweats and nausea, vomiting, diarrhea, which resolve shortly after a day or 2 or 3, and that's the end of it. And that is not an addiction. That is just a natural, normal physiologic body response to having taken that medication. Substance use disorder is basically what we would call addiction. And this is a definition that came out in the last several years. There's something called the DSM-5, which is a large book that includes all the different diagnoses that the psychiatrists and psychologists have come up with. Different things, substance use disorder, depression, anxiety, they're all broken down into very specific areas. And they use very specifically defined criteria to define different diagnoses, one of which is substance use disorder. So substance use disorder is based on 11 criteria, and these 11 criteria include longer period of use, larger amounts being needed, unsuccessful attempts to stop the particular substance, cravings where you're desiring more of it, or continued use with negative consequences. And then at the bottom, you see there tolerance and withdrawal, which are a component of that, but not the whole piece. They're broken down into 3 areas: mild, moderate, and severe, depending on the number of criteria that you meet for that specific substance that they're dealing with. A broader definition that doesn't quite get into specifics like the definition is ACDE, which I kind of like because it just gives you a general idea of addiction in general and can include both substance addiction and behavioral addictions, which I'll talk about a little bit more. A is for the inability to abstain from using that substance or participating in that behavior. B is impairment in behavior control, which is basically saying that you're having difficulty controlling that behavior. C is for craving or increased hunger for the drugs or the rewarding experiences that the behavior provides. D is diminished recognition of significant problems with one's behaviors or interpersonal relationships. So basically, you're starting to lose a lack of awareness of the consequences that the use or the behavior is causing for both yourself and those around you. And then E is for dysfunctional emotional response. That can mean a variety of things, from a labile mood to anger to depression, that kind of thing. There's also this concept of risky use versus addiction I just wanted to touch on. Risky use is basically where somebody tries a drug or a substance or a behavior and doesn't become addicted to it and may even try it on different occasions. This would fall into the category of a teenager experimenting with alcohol or any other number of things and doesn't necessarily mean addiction at all. So just because somebody happens to be has used one of these substances or tried it or tried the behavior does not necessarily mean they're addictive, but it does fall into risky use because there are risks related to that, including impairment when you're using it to progressing to an addiction. So drug addiction is the prototypical form of addiction. There are others, which I alluded to. The drugs we typically think about are alcohol, which is probably the most common one, or possibly nicotine with tobacco. Opioids, of course, with its recent focus, methamphetamine, cocaine, the benzodiazepines, which are the Xanax and the Ativan and those types of things. But the other types of addictions that are not quite as well defined, but certainly can be problematic. The most common one we would hear about would be a gambling addiction, which is more of a behavioral type of addiction. There are addictions related to shopping, sexual behavior addictions, and again, they fit the criteria of addiction that we previously talked about, the ABDCE sort of criteria. Next, I wanted to move into the history of addiction and addiction treatment, just to kind of give an overview of the last 100 to 200 years, but also to emphasize that this issue with addiction is not something that is new to humans and not even new in the last 200 years. It has pretty much been with us as far back as we can ascertain that we have been around. From There's basically three historical constants that we have looked at. One is that suffering is part of the human condition and has been since the beginning. The use of intoxicants based on research that's been done has been present since early humans and is also seen in other species. There's been studies done, for example, of elephants that will seek out intoxicating substances, even that occur naturally within the environment. And then ever-present addiction has been present, again, throughout history. More recently, in the last 100 to 200 years, this is not meant to be comprehensive, but I just wanted to touch on the different types of things that have gone on over the last many decades. In the mid-1800s, there was noted to be an increased use of alcohol. Early 1800s to early 1900s, we had these patent medicines that were coming out that included opioids and cocaine mixed in with them. There was a cocaine crisis in both the US and England in 1910. In the 1940s through the 70s, we've seen heroin use that's been ongoing with rises and falls over different periods of time. An example was the end of the Vietnam War with the returning veterans. We saw a peak in use then. Since the 1960s, marijuana has been ever present and has certainly gained a lot of attention in the last several years with its legalization and decriminalization. The early 1980s saw cocaine transitioned into a form called crack cocaine, which again had some different properties that made it a little more dangerous to use. And there was a major issue with that back then. The 1980s up until now have also seen increased access to the behavioral addictions, specifically gambling and sex products, primarily through increased in, for example, the number of casinos, as well as the internet and online social media access to many of these things. The 1980s saw methamphetamine. In 2000s, prescription opioids, which we will get into in a little bit more detail, which led into the current situation we're in. 2010, we saw THC analogs, which are basically marijuana, synthetic marijuana, if you will, which included K2, spice, bath salts. Those are showing continued use to this day. And then 2015 up until the present time, even more recently in the last year or two, is a resurgence of methamphetamine. So as you can see, this issue of addiction and substance use and behavioral or just addiction type issues have been with us for quite a long time. So jumping into our specific issue now, the current opioid crisis, it's basically been looked at in three different waves. One is the starting increasing use of the prescription opioids. And these started out primarily with morphine, and then in the late 1990s, early 2000s, we started to see hydrocodone and oxycodone in different formulations getting used significantly more, primarily prescribed through the medical community, often appropriately, but many times inappropriately. And as we've now seen in the media, the issues with the pharmaceutical industry, and the manipulation that occurred there and is now being addressed. The second wave started around 2010 when the government basically identified the misuse of these prescription opioids and started taking measures to restrict access to the prescription medications, primarily through prescribing monitoring, which I'll talk about more in a little bit, but ultimately what it did was decrease availability of the prescription medications and also allowed the prescribers to identify those that were seeking out prescriptions outside of what would be used for basic medical issues. That unfortunately did not solve the problem of the addiction to these prescription medications. And so people were getting cut off of their prescribed medications, were still addicted. There was not any infrastructure really set up at the time that it was robust to deal with the specific addiction. So they sought out heroin, which the market, the drug market, quickly identified as an opportunity. They began increasing the production of heroin, making it more available and making it less expensive. This primarily was available either through snorting it or both injecting it. That escalated, 2010 through 2013 or 14. And then on the scene came this medication called fentanyl, which was significantly stronger than the heroin and much more potent and also inexpensive. With that, basically what we saw was a significant increase in the deaths related to overdose, specifically in young people who had been using heroin. And that sudden rise in the deaths really stimulated all of the attention to the situation that we're seeing now. So to the question is, why is this particularly so explosive? Basically, it's due to the fact, there's many factors involved, but primarily is the scope of the people that became addicted through the prescription medications. It was in numbers that were unprecedented. And then the subsequent transition to the quote illegal drugs of the heroin and the fentanyl, and then the big rise in the deaths related to that kind of caused this to be an epidemic that we've seen unlike any other, and it also crossed socioeconomic boundaries unlike any other that we've ever seen before, basically affecting everyone everywhere, regardless of income status, social status, living status. So historically, addiction has traditionally been viewed as an individual problem as opposed to a more societal public health perspective, which we've now transitioned, but initial several decades it was thought to be more of an individual issue, which we'll get into a little bit more. But transitioning into treatment, how addiction has been treated over the last 100 to 200 years really started back in the early 1800s with the recognition that alcohol was becoming a problem and the creation of these sobriety houses. There was a temperance movement in the mid 1800s, along with asylums that were set up to help people with alcohol addiction specifically. And movements against using alcohol. And again, this is in the setting of it being viewed as an individual problem, often related to moral or spiritual failings, as opposed to it being a actual disease. In 1914, something called the Harrison Act was passed, which is important, and I'll get into that in a few minutes. But it was the beginning of what we call the war on drugs, which is basically continued from 1920 up until now and is still ongoing. Prohibition occurred in the 1930s with basically banning of alcohol. Did not work out very well and was subsequently reversed. We then transitioned in the 1950s to Alcoholics Anonymous as a treatment mode and the different 12-step programs, increasing individual and group therapy, therapeutic communities, and also now medication-assisted treatment, which again is not something new, but has had a resurgence. So going back to the 1914 Harrison Act and the origin of the war on drugs, this act basically made certain drugs illegal. So prior to this time in 1914, drugs like heroin, cocaine, marijuana, tobacco, alcohol were not really regulated and were not illegal. So heroin was a medication that you could be prescribed by a physician. Morphine was another one, which is a similar drug to heroin. And these were also found, as I'd mentioned, in patent medicines, apparently in Coca-Cola. Cocaine was a small ingredient in that when it first came out. So these were started to be recognized as being problematic. So these drugs were made illegal. Interestingly, at that time, tobacco and alcohol were deemed to be legal, even though these are two of the most toxic uh, drugs that we happen to deal with. And there are reasons for them having been made legal and not illegal, primarily due to their economic status between the tobacco and alcohol industries, had a significant influence on those not being made illegal at the time with the Harrison Act. At up to the point of this Harrison Act, I'd mentioned medication treatment for addiction. And prior to this time, physicians had recognized that treating opioid addiction, you could often use opioids to treat the addiction itself. And instead of somebody buying illegal drugs off the street, it could be treated with prescribed morphine or heroin. This act actually prevented and made it illegal to provide any treatment like that, which ended up resulting in that really being removed as a treatment option until really the last decade or two. So this war on drugs that the Harrison Act instituted involves a lot of different aspects. And we have to ask the question, and this has been asked over and over again, has this war on drugs been effective? And the opinion of many, including myself, is in fact that it really has not been overall, given the status of what's going on today. And we're going to take a look at some alternative approaches to what the war on drugs has really taken. Again, kind of relating back to the war on drugs issue, right up until the past few years, we were really looking at opioids as being, quote, the demon drug. What will our next demon drug be? Methamphetamine is now becoming very prevalent across the country and is primarily a response to the restriction on the opioids that we're seeing. Again, speaking to this idea that addiction is a underlying issue that has various drugs and behaviors that it just happen to be particular at a specific time. So unfortunately, the Harrison Act, which was a legal law that was passed, doesn't affect the brain center that drives addiction. And this we're going to talk about a little bit more in the different causes and roots of addiction in human biology. But just because the Harrison Act was passed didn't mean that people still didn't have addictions and weren't going to be seeking out different substances. Same that happened with the opioid crisis and the prescription medications. When the supply of the prescription medicines dried up, the opioids dried up, those people still had addictions, and those addictions left untreated, people were going to seek out treatment the best they could, which resulted in the transition to the heroin. The Harrison Act led to a robust law enforcement response and a thriving prison industry. Both are an important component of the overall picture as far as illegal drugs, but they are not the primary. They are a piece of the treatment. We saw increased rates of incarceration, which again has led to a imbalanced prison population affecting certain economic and social minorities more than others. The recent bail reform here in New York State has been an attempt to rectify some of that. And even with all these legal law enforcement prison sentences, we've seen absolutely no abatement in the addiction problems that are occurring. It actually continues to increase and get worse. So going back to the individual frame of reference as far as addiction goes. We have fortunately transitioned, or are in transition of a model where it was looked at to be a personal failing, if you will, with moral and spiritual weakness, and have transitioned to a view of a chronic disease, a chronic relapsing brain disease. And this has really been an important transition in the way we treat it and deal with it. Though, again, it's not 100% yet. It's still, there's still the stigma attached to addiction. And that's something actually that will be coming up in one of the upcoming webinars on that. Addiction is ongoing, and we are still working to get by that, but we've made quite a bit of progress towards transitioning to a chronic disease model. The other transition that is occurring is that we're also starting to look at this issue from a societal and population health frame of reference outside of the individual issue. This is a quote that came from actually Bruce Alexander, who had written a book on addiction that I'll reference at the end of the session. But addiction is not so much a problem of aberrant individuals as a latent human potential that expresses itself universally under a particular set of circumstances. So basically what that is saying is that addiction and the potential for addiction is present within all of us just because of our human nature and our human biology. And it manifests in some and not in others for a variety of reasons. From a broader, more societal perspective, and as far as addiction goes, an idea that I wanted to bring up, and we'll get into a little bit later, is this concept of displacement theory, which is something that's really come about in the last decade and has gained a little bit more traction, though it's not fully accepted. But it's this idea of loss of psychosocial integration, which is where a common example is displacement from one's tribe. So basically, for whatever reason, we as individual humans lose the connections around us that are part of our tribe, if you will, whatever that tribe may be, that provide important psychosocial supports in allowing us to deal with the day-to-day challenges that life presents us with. And I'll get more into that a little bit later, specifically. Treatment overall has shifted away from more moral or spiritual weakness to a chronic relapsing disease model. And we're also starting to transition to a more holistic approach, rather than just focusing on the individual and what we can do for that person, to looking at a more public health societal perspective, where we're developing more robust infrastructure and changes in public policy. Again, these changes are being driven by the current opioid epidemic, but will be applicable to any of the various addictions which we are encountering. So next, I wanted to venture into the concept of, or the idea of neurobiology of addiction, which is more of the human physiology, specifically as to why, part of the reason why we have a predilection or that latency to become addicted to medications or substances or behaviors. First thing I just want to lay out here is it's a very complex topic, and it's an evolving topic as more and more research is discovered about the complexity of the interactions and connections within the brain and our environment. I'm going to try to simplify it down to a very basic model. This is a picture of all the different brain pathways and the wiring in the brain, the different things that interact to drive addiction. And the reason we have this system set up in our brain, a reward behavioral reward system that serves a purpose from an evolutionary response, but also can get hijacked. The bottom line is there's this neurotransmitter, which is basically a neurotransmitter is a chemical inside of the brain that allows the different areas of the brain to communicate with one another. That's through a chemical called a neurotransmitter. And dopamine is responsible for reward and pleasure. And the reward and pleasure system is something that has developed over hundreds of thousands of years as an evolutionary response to different things in our environment. The reward and pleasure system is designed to reinforce actions that are basically beneficial to reproductive success or allow us as a species ultimately to reproduce and continue to move forward. Some of these actions that it reinforces are things like eating and pleasure we receive from eating to reinforce that, avoiding things that are toxic to us, sexual behavior for reproduction, those sorts of things that are essential for our survival. And this system with dopamine at its base was designed and molded through the evolutionary process to support this. So it's very much a fundamental part of who we are. The drugs of addiction and also the behavioral types of addictions affect these various neurotransmitters. And each drug affects an individual transmitter, but ultimately results in impacting the dopamine levels in the brain. We won't get into all of those specifics, just kind of to sum it up that dopamine is one of the final pathways that all these different drugs or substances affect. So addiction hijacks the pleasure and reward pathways of the brain. Basically, the addictive behavior, addictive substance interacts with this dopamine reward pleasure system and hijacks it and substitutes itself. This area called reward, judgment, motivation, memory, go, no go is basically talking about, if we do something that's good for us, we get rewarded, or our brain rewards it, makes us feel good. Our judgment is based on this, can be good or impaired. Our motivation to move forward and do things. Our memory of certain things is impacted by this dopamine system. So memory of pleasurable activities is affected by this. And then the go, no go, which is kind of the flight or fight kind of response, touching the hot plate and withdrawing from it, that kind of thing. These areas of cognition are all influenced by dopamine, and they get rewired for years after stopping one of these substances or drugs that impacts the dopamine system, which is why this is now considered a chronic disease, because of these changes that occur in the brain and the rewiring that occurs in the brain. And the younger one starts and is exposed to these different substances, the more rewiring that can occur early on and making recovery more difficult. This rewiring is responsible for relapse after years of sobriety. So many times where somebody has been doing well, they've been sober for many, many years, and all of a sudden, out of the blue, they have a relapse. And again, that is tied into this dopamine system that has rewired the brain and has basically imprinted these memories of positive feelings from the behavior or the substance that still linger years and years down the road. This issue of physical withdrawal, which I touched on earlier, the physiologic withdrawal symptoms, does drive addiction and ongoing use, but it only plays a small role in addiction. It will drive use for short term. So, somebody is using opioids and they know if they don't get another dose of heroin in a couple of hours that they're going to start to feel sick, which is called dope sick. That will drive them to go ahead and get another dose of heroin or nicotine or alcohol or whatever they're using. That, however, is short term, days to weeks, and can be overcome with medications as well as counseling. But once they're beyond that physical withdrawal period, there are all these other brain circuitry changes that drive ongoing use and recurrent use. So predisposing factors for addiction. I wanted to touch on those because those cover several different areas. And this gets into the question of why some people develop addiction and others do not. I'll start from the individual perspective, and this relates more to the dopamine system and the neurobiology of the brain and some other specific environmental and psychosocial mental health issues. So again, all humans have the latent potential for addiction due to our neurobiology. So each one of us, because of this dopamine reward system, has a potential to become addicted. And that's just the basics for every one of us. From an individual perspective, there are basically three areas that interact on this latent potential for addiction that include our genetics, environmental factors, and psychosocial factors. Genetics is currently a very active area of research. There are different percentages that I've seen out there. The most common one I've seen quoted basically says that genetics accounts for about 50% of our individual predilection for becoming addicted. Those other environmental and psychosocial issues take care of the other 50%. Though this again is somewhat controversial. There hasn't really been a specific addiction gene that's been found. This is often a complex interaction of genes relating to different things as far as the way a particular body will metabolize or break down drugs, how those drugs spread throughout the body, how strongly they attach to different areas, and how they interact with dopamine, because that can be very different between different people. A good example is alcohol. In certain cultures, because of the genetic differences in the enzymes in the body, alcohol can be toxic to that group of people, whereas another culture with a different set of enzymes, it doesn't have as much of an effect. The environmental factors include lower socioeconomic status is one of the predisposing factors, though with this latest opioid epidemic, that is proven to be less of an issue. The age of exposure, which I'll touch on very briefly, as we're developing our brains, especially in adolescence, early and late adolescence, our brain the dopamine system is setting up priorities based on the response to things in the environment. So it may put number one priority food and eating well. You know, the dopamine system saying, okay, this is very important. I'm going to reward when they eat things that are good for themselves. Sex is another one, which is why the dopamine system prioritizes that. But what happens with the early exposure to these drugs that affect the dopamine system is that it'll actually place that drug or behavior higher up than those basic things that are essential to our survival. And that rewiring leads to some of the behaviors we see in people who are addicted, who stop eating and put aside their health in order to pursue that specific addictive substance or behavior. The availability of the particular substance or behavior is also important, and one's peer group is a factor. If people around you are using or family members use, that also is one of the predisposing factors. Psychosocial factors include your coping mechanisms, how you cope with stress, adversity, changes. There's something called ACEs, or adverse childhood events, which are anything from divorce to foster care to assaults to abuse that occur early on that could potentially impact the way your predisposition to addiction. And then concurrent mental illnesses also play a role, a significant role. Often people are using substances to try and self-med for an underlying mental health disorder. From a societal population perspective of the causes for addiction, I'll get more into this issue of psychosocial displacement. This dislocation theory is based on this loss of psychosocial integration, which is defined as the profound interdependence between individual and society that normally grows throughout one's life. And this is basically just saying that human beings are not psychologically self-sufficient. We are social beings. We require a strong social fabric around us in order to do well in life. This includes family connections, friend connections, social connections, work connections. All of that is an important part of us. This dislocation theory views addiction from a historical perspective in the loss of one's tribe. There are historic examples of this. The most common one would be the native inhabitants being displaced. Our Native Americans themselves here in the United States, up in Canada, we've seen it in Australia with the Aboriginals, who have traditionally never had any issues with addiction or addictive substances, even though they had availability. Once these cultures were displaced and placed on reservations and had their culture disrupted, their beliefs, their communication, their languages, many of them fell into addictive behaviors. And there's been examples where once those changes are reversed, the addictions basically go away themselves. Civil war is another one we see, which is ongoing, where a large number of people are displaced from their basic culture and their basic physical locations. Major environmental disasters. The more common ones that are easier to take a look at. Today's talking about today, we get into a broader issue that we're looking at. But this quote, again, from the same as before, today's rising tide of addiction to drug use and other habits may be the consequence of people, rich and poor alike, being torn from the close ties to family, cultural, traditional spirituality that previously constituted the normal fabric of life. And again, all those traditional things that we just talked about cause that, but there are issues now in modern culture that are leading to very similar results. And these are tied to consumerism, social media, globalization, and even with all this, what I'll call connectivity through all the internet and social media network and Amazon and shopping, this loss of connection has become even more intense, and addiction is a way of adapting to this sustained dislocation that we are all experiencing. And again, this is a developing theory, not accepted by all, but certainly seems to, from my perspective, have some very valid points. Next, I wanted to move into current treatment and some general concepts. No single treatment alone is typically effective. Treatment and recovery is a long-term process measured in years. There's no quick fixes to this issue. And again, there's no one magic bullet. It is a multi-faceted approach involving different entities and methods and systems. And looking at the chronic disease method, that relapse is expected because of the changes that have occurred in the brain. And just because somebody is successful and then relapses, again, that's not a moral failing or a lack of willpower. It is very definitely related to the biologic changes in the brain. So we've really adopted a collaborative care model, which the infrastructure over the last 5 to 10 years has increased significantly and continues to do so because of the recent opioid crisis. It involves on an individual level the MAT, which you're going to hear quite a bit about. That's medication-assisted treatment. The mutual support, which are the groups like the 12-step groups, Alcoholics Anonymous, and counseling, professional, direct one-on-one counseling groups, combined with community services that are put into place in public health interventions. Care I just wanted to touch on. The first step is often detoxification, which is basically a term for treating the withdrawal, which is the physical withdrawal, which occurs in the first several days to weeks after stopping the addictive substance. This can be managed in a variety of settings, all the way from outpatient to residential to inpatient, depending on the severity, because it can sometimes be a medical emergency depending on the substance. Individual treatment, medication-assisted treatment. Most commonly now for opioid is Suboxone and methadone. I won't get into a lot of the details about that. There are some others for alcohol that have shown some promise, but no silver bullets here. They all need to be combined with the other modalities in order to be successful. Professional support, which would be formal counseling, and then mutual support, which are groups like AA and such. Again, the medication-assisted treatment, there's 7 FDA-approved medications out there. Again, the most common ones now are related to the buprenorphine, which is the Suboxone, the naltrexone, methadone. For alcohol and nicotine, there are others, nicotine replacement therapy. Direct professional counseling includes group and individual therapy, motivational interviewing, cognitive behavioral therapy, network therapy. These are all specific counseling techniques that you would encounter under professional treatment. And then mutual support groups, which are peer support groups, which we've developed for the opioid crisis, where you have others that are in recovery that are available to work with you and respond directly if you're dealing with addiction. 12-step programs, recovery coaches, all of these are currently very active and in place. From a public health population-based perspective, we'll get into some of the more controversial things that are going on right now, but nonetheless important ideas. Public health interventions include age restrictions on, let's say alcohol being 21, tobacco now being 21 in this state. Point of sale stings going in, again, focusing on alcohol and tobacco, vaping now, and probably marijuana in those areas where it's legalized. We'll go in with people that are underage and do sales, and then there's consequences for selling to underage people for that particular business. Advertising restrictions, which we've seen develop over the last several decades regarding tobacco, alcohol, most recently removal of tobacco products from, say, pharmacies. School-based education programs, which have been going on for quite a long time. Pill take-back programs where you can bring in extra medications that you find sitting in your cupboard and dispose of them in a safe way. Treatment court, which is something where if you've been convicted of a drug-related issue, you can go into what's called a drug court, and they will offer an option of mandated treatment versus going into jail, which actually has been shown to be almost effective as voluntarily going into treatment. Decriminalization, which we've seen with marijuana. Other countries have decriminalized substances such as opioids and had some success with that. And then outright legalization, which we've seen with marijuana in a number of states in the country. Something I wanted to touch on is the Vancouver experience, which is Vancouver, British Columbia up in Canada, which has been a model that has been looked at specifically for opioid addiction, which has been very successful, but somewhat controversial. There's 4 basic pillars that they approach. One is with prevention, which is through education and all these other methods that we talked about. Second is direct treatment, which we've touched on. Third is harm reduction, which is basically a way of acknowledging people are addicted and they're going to stay addicted for a period of time. And what can we do to prevent them from injuring or killing themselves or dying from their addiction prior to getting treatment? And then the final piece of that is enforcement, which falls under the war on drugs category, which is an important component of the overall approach, but has received a disproportionate amount of funding compared to some of these other areas. So the harm reduction strategies, which I wanted to touch on and you'll hear about, which are quite controversial, include safe injection sites where people who are injecting opioids and other substances can actually go, and instead of having to do it in abandoned houses and alleyways, can now go to a medical site where there's typically a nurse and counselor staffing them, and they can inject under supervision. That way, if they get into trouble and they overdose, they can have it reversed immediately. And they also have are provided opportunities for counseling and medical care and entrance into the system. There are needle exchange programs, which help prevent some of the transmitted sexually or drug transmitted diseases, including HIV. And then prescribed illicit drugs, which is not something that we've seen in this country. But again, there are certain countries where they're prescribing heroin in order to treat addicts, figuring that it's better to prescribe the medication, prescribe it as a medication in a controlled environment, rather than allow them to get it on the streets. Though our medication-assisted treatment are not illicit, they're actually proven drugs, and that kind of fits into that. There's mounting proof that these are strategies that are effective, that they do not actually increase illicit drug use. They do support effective addiction treatment because they provide the opportunity for when the addicted person is ready to seek care, they can get it. But there are many ideological and political hurdles to overcome, which are significant. So there's some recommended readings depending on your level of interest and whatever your background is. I also use these 3 books to assist me with this presentation. The middle one is basically a textbook on addiction and is used as part of, from the American Society of Addiction Medicine. That's pretty dry and factual. The one on the right is the one that really gets into this concept of dislocation theory and loss of psychosocial integration. And again, more of an academic text, but very interesting. The one on the left is a very interesting book that was written by this physician up in Vancouver, who has been part of this movement to treat addiction in Vancouver. And he writes there of his experience in a more of a story format. So it's a very readable book. And I would highly recommend that one for anyone that has an interest in seeing how that system worked and some of the things that are being taken from that as far as treating the addiction in our own country. In conclusion, addiction is an ever-present phenomena with ever-changing focus on different drugs and behaviors. So right now it's opioids, methamphetamines coming up, multiple behavioral addiction type issues. It is a chronic relapsing brain disease that is not the result of any sort of individual moral, spiritual failing, lack of willpower. It should be viewed from both an individual and a societal perspective. Effective treatment requires collaborative approach involving both individual and community-based interventions. And the 4-pillar model, I think, is an effective one that deserves a recognition and further implementation involving prevention, treatment, harm reduction, and enforcement. And just to end, I just want to say that it truly takes a community to treat addiction. It requires everybody's work and input, from the addicted person to families to friends to our healthcare system to law enforcement, everybody. So I will end there and take any questions now that anybody may have.
Thank you so much, Dr. Collins. That was quite informative. I learned a lot. I typed in the chat box for everyone. If you have any questions, let me know. You can type them there or let me know to unmute you. We can unmute and actually let you talk to Dr. Collins. And you finished right on time, so that was very good.
Good.
So good timing. I did wonder, while we're waiting for some questions to come in, you talked about the loss of connection. And I just wondered, what feeling does the actual addiction replace to replace that loss of connection? Like, what does it do so that people feel connected? Because I would think that addiction would make you feel so isolated.
Well, that's kind of the paradox to it, because that's the ultimate problem with the addiction substance or behavior, is that it doesn't replace the connectivity. Mm-hmm. I think it actually more dulls down the pain that comes from not being connected. And it ultimately, at first it seemed great. It kind of makes it not a worry. I don't need that connection. It's not an issue for me, but that ultimately ends up being a fallacy because that need for connection is fundamental to our well-being.
Thank you. And a lot of comments coming in saying, thank you for the presentation. It's great. I learned a lot. And do you see a connection with ADD and addictions?
That is a good question. It certainly is a component of it when you look at the psychosocial mental health sort of reasons for addiction. I know there's actually been, I don't know recently, but I know, several years ago, and I haven't looked lately for any research that's been done in recent years, but as of, 10 or 15 years ago, there's certainly was some correlation between untreated ADHD in adolescence leading to increased incidence of addiction. Now, whether that's due to the ADHD itself and the brain changes that are there, that, or if it's related to the behaviors that come with ADHD or the issues that come with ADHD that result in isolation and disconnection, that I don't know, but there's definitely some correlation with ADHD, yes.
Okay, thank you. So another comment came in: the displacement theory has been proposed by others as an overall issue for the problems in society, and the addiction piece as a replacement for the displacement. So the proof that it does not replace is overwhelming. So thank you for pointing it out.
Certainly. Yes, I found that to be, as I learned more about it, it really made a lot of sense to me, and is so to many others as well.
Mm-hmm.
And I will just comment on that as well. It's also not been a traditional mindset in the addiction treatment community as far as including that component as a piece of it over the decades. So it's really an up and coming thing as to how we address that as part of the addiction treatment process.
Okay, we have one more question. Have you conducted any research in regards to weaning one off of opioids and trying medical or medicinal marijuana, or reviewed any research?
I have not personally done any research on that. I've had some anecdotal experiences on a very limited scale that there's some decreased use in the medication assisted treatment with the medical marijuana, but again, that's very, very anecdotal. And I have not seen any outright research on it yet. I think that's in process and up and because it's such a new thing, and that the process of recovery from addiction is such a long-term process. I think we'll have more of that coming as we move forward, but nothing solid certainly yet at this point.
Okay. All right, well, Dr. Collins, on behalf of the Finger Lakes Geriatric Education Center and the Western New York Rural Area Health Education Center, thank you so much for your presentation today and taking the time to give us this very insightful and informative overview of addiction. We truly appreciate it.
Thank you.
And with that, I will end the webinar. Thank you, everyone, for joining us today, and we hope to see you next month with Ednita Wright, and she will be presenting on wisdom keepers and opioid use. So have a great month, and we'll talk to you soon.
Very good.
Thank you.